Good evening, everyone. I'm going to start my lecture now, and we are also live on YouTube. So I'm sharing the link with you all on the WhatsApp group. So this is just a minute. Let me share that first, so that those who cannot attend here will be able to attend over there. So we are going to do a quick revision of the coma slides I had taken. Because I was not well at that time, I couldn't take the part 2 on the scheduled time. So I'm doing it today. So as I had said, coma is a topic which all specialties should be aware of, because altered sensorium is something that can happen to anybody. So as we saw that in casualty, you will be exposed to these patients who are either drowsy, stuporous, or comatose. In the ICU, you will have them. Sometimes a ward patient who is stable suddenly has altered sensorium. And in OPD also, you could be brought patients to assess for their change in sensorium. So we saw that there are different states of consciousness: conscious, REM sleep, non-REM sleep. And when it becomes abnormal, then that is altered sensorium. And we went on to discuss consciousness, and we saw the difference between sleep and coma. Then we saw the different situations in different contexts कि ward में क्या हो सकता है, OPD में. Suppose now you are asked as a doctor, as a budding doctor, or suppose immediately when your internship starts, you are asked कि घर आ जाओ देखो इनको क्या हो गया है. So then you need to know. So we saw different states. We saw the minimally conscious state, which can occur with head injury, or after cardiac arrest patient is resuscitated and not fully cognitively improved, so they can land up in something known as minimally conscious state, where there is profound dementia and some rudimentary behavior, making the caregiver feel that maybe he's going to improve. So minimally conscious state can very rarely show some amount of improvement, but very often they just be in a persistent state, that is known as persistent vegetative state, or apollic syndrome, or neocortical death. That means the personality is not there anymore. And akinetic mutism, there is a patient right now admitted under us. Patient has got pontine stroke, and he is able to move his eyes, and little bit of his facial nerve nucleus is working, because of which sometimes he goes into crying spells, but otherwise he has got quadriplegia. And we are planning his PEG gastrostomy. We are planning his tracheostomy is also has already been shifted from a Portex tube to a metallic tube, because he's going to need it for a long time, because his 9/10 nerve, which is below the level of the pons, is also not working properly. So that is a locked in syndrome, where the ventral pons is damaged, because of which he is actually, if we do his EEG, his EEG is going to be normal, because his thalamus and thalamocortical projection. So it's a very terrible state to be in. It's called as a locked in state, because a conscious person is locked inside a paralyzed body. Whereas coma vigil or akinetic mutism, it is a little, uh, I don't know whether to call it better, but it is a slightly lighter side of minimally conscious state, where the patient is motionless and mute, silent and inert, bilateral frontal. When there is hydrocephalus, this is what happens, because the medial frontal lobes have the networks of motivation, and when those are pressed, patient is absolutely unmotivated and lying motionless, but some reflex movements of the limbs can occur. So that is coma vigil. Patient looks awake but is absolutely not interacting with the environment. That is akinetic mutism. So these are different levels. So persistent vegetative state. Then in ICU we saw about brain death and the moral ethical dilemmas, and the legal situation regarding organ transplantation. Therefore, the neurologist being important parts of giving certification for brain death. And those of you who are interested, in India, we do not yet have a unified definition of death. So a brain death patient is certified as dead only if he is eligible for, if his relatives are willing for organ transplantation. If they are not willing for an organ transplantation, unfortunately, as yet, we cannot certify him as death, and we continue to treat him till his heart stops. So we are fighting, we are as a group of advocacy people, as a group of palliative neurologists, we are fighting for this. We are fighting for a unified definition of death. सी ऐसा ज़रूरी नहीं होना चाहिए कि सिर्फ ऑर्गन ट्रांसप्लांटेशन के समय ही ब्रेन डेड पेशेंट को हम रिटन सर्टिफिकेट दे सके. वी शुड बी एबल टू गिव इट फॉर एवरीबडी बिकॉज कंटिन्यूइंग ट्रीटमेंट इज एन अननेसेसरी फाइनेंशियल ड्रेन फॉर द केयर गिवर्स. So there are many issues which as students you are not exposed to, but I like to give you a glimpse of the actual life of a clinician. So brain death is irreversible damage we had seen, and as I said, there are many ethical, legal, social, psychological issues. So we had seen absence of cerebral function in some countries. Transcranial Doppler is also mandatory. Then brainstem function, bedside tests, and the apnea test and the caloric stimulation test were wait for 24 hours in adults and 48 hours in children. Then we saw the anatomy and physiology of coma. We saw the reticular activating system which is there in the brainstem and how it is connected to the thalamus, and then the thalamocortical projections go to the whole of the cortex. And we saw that the different neurotransmitters play different roles. The cholinergic system, which utilizes acetylcholine as a neurotransmitter, situated in basal forebrain and mesopontine. Then the monoaminergic system is there, which consists of dopamine, norepinephrine, serotonin, and histamine. Each has their specific location and pathway. So we saw this. Sorry. Then we saw the serotonin synthesizing neurons. So all these neurotransmitters, they have a beautiful orchestra, and thalamus in the consciousness system. We are not taught about the thalamus. We as humans started understanding the thalamus much later. It is only in recent years with all the functional imagings and the SPECT and the PET and all these metabolism based imaging studies that we have started understanding the subcortical system more, because initially the neurology was driven by investigators who stimulated the cortex and studied the humans. But with these functional imaging systems and the metabolism based studies, we are able to understand these structures better. And thalamus is much more complex than what we had imagined. Each thalamus itself has got subparts, and the midline thalamus, which is that is where both sides of the brain, very few sites where both sides of the brain are in direct contact with each other, and thalamus, the central part of thalamus, is one of those areas. So although consciousness is affected, different level of interruption results in different consequences. So cerebral cortex, then you have impaired awareness or the vegetative state. If thalamus and thalamocortical are gone, then you have impaired arousal, patient not responding to the environment. Then that is this comatose state. Upper brainstem, that is damaged. And if the pons are damaged, what happens is that below pons, sorry, here pons are damaged. Below pons, the brain is paralyzed, the person is paralyzed. Above pons, that means thalamocortical are intact. It's a very sad state to be in. It's the locked in state. And as I told you, right now, patient is here. So brain death is when everything above this is damaged. So that is brain death. So, as we had seen, there are different aspects of history. History is not from the patient. History is dependent, because patient is an altered sensorium. History is dependent on the observation skills of relatives and attending people. Intelligence of observers is important, and symptomatic expression of underlying disease will be occurring through that altered sensorium. Then we saw a few cases in casualty. This was the hemorrhage, pontine hemorrhage. Then this was the metabolic encephalopathy with triphasic complexes. Then this was hypoglycemia. So we saw different causes, and this was non-convulsive status, which is something we should always suspect a person in whom there are no other explanations, and the sensorium, instead of remaining steadily in a one level, sometimes stuporous, sometimes drowsy, sometimes comatose, sometimes minimally conscious. Like, so it's fluctuating. You know, it's going along that wave of kabhi acha kabhi. So nurse is giving you कि नहीं sir सुबह तो अच्छा था. Your resident doctor is saying कि नहीं मगर मैं आया तो बहुत comatose थी. That means you have to, red flags have to rise up in your mind कि this could be non-convulsive seizures happening in the patient. So then we saw that even absence seizures can occur as status, and that can be proven only in the EEG. So this is where we had reached that suppose there is a unilateral abnormality. So if there is a unilateral abnormality, then you think of structural lesion and you do imaging. Suppose there is no unilateral abnormality, like bilaterally signs are abnormal, bilaterally abnormal signs, then it could be a midline lesion like pontine hemorrhage, hydrocephalus, that kind of a thing. If bilaterally signs are normal, then we are going to think of metabolic causes or infective causes. So subarachnoid hemorrhage can also come. So whether if the bilateral signs are normal, then you have to look for neck rigidity. If neck rigidity is there, then it is infective or subarachnoid hemorrhage, which can also have neck rigidity because the blood is irritating the meninges. And if there is no neck rigidity and there are bilaterally normal signs, plantars downgoing, reflexes are bilaterally equal, movements थोड़े थोड़े उतने ही हो रहे दोनों तरफ, then and no neck rigidity, then you have to think of metabolic or toxic causes of altered sensorium. Barbiturate ingestion can look like coma. It can even look like brain death. So before certifying brain death, you have to always rule out barbiturate. अगर patient ने overdose तो नहीं लिया, patient is on phenobarbital for epilepsy and he consumes all those tablets, then he can come looking like coma with bilateral normal signs and no neck rigidity. But then you cannot declare brain death unless it has been proved that those barbiturates have been washed off. Another situation where brain death cannot be declared even in the presence of bilateral signs is hypothermia. So when the body temperature is very, very low and you are getting signs of which are bilaterally abnormal, you are getting bilaterally abnormal signs. So in that case, then patient uh, could be having all those signs because of the hypothermia and not because of brain dysfunction. So that is, so even in presence of hypothermia, we cannot declare brain death. So these are two places where even the, in hypothermia, even the EEG, because the brain is also hypothermic, so the EEG can also mimic a very, very low voltage pattern, but we cannot declare brain death in presence of lowered body temperature. So, so now we have to think about, can we localize? Then if the approach for a comatose patient is different, because otherwise the conscious patient is giving his own history. And in neurology, we keep on saying ki history is important, history is important, history is important. But here is a situation where the patient himself is just unable to give you any information. So here you have to depend on your own observational skills and you have to focus on the eyes of the patient. They say that the eyes give half the information of the brain. So eyes, including pupils, including fundus, everything has to be seen. Eye movements have to be seen. You have to hold up the eyelids and you have to just look at what is happening to the eyeballs. Are there rowing movements? Are there bobbing? Are there popping movements? All these different movements have been described for the eyeballs, and depending upon which part of the brainstem the lesion is, you get typical eye signs. You see what happens to the doll's eye movement, that gives you whether the oculocephalic reflexes are good or not. So that means brainstem integrity is maintained or not. So eyes give you a lot of information. So any patient who is comatose, unable to speak, unable to give you history, you have to do detailed examination and cannot be tested. नाम की चीज नहीं होती, even if the patient is, so cannot be formally tested, but you can test. You can test whether the patient is maintaining balance or not. You can test tone. You can see whether flailing is there or not. You can keep the limb in a particular position and see whether he is able to retain that position or not. So there are a lot of ways in which you can give deep painful stimulation and see what's happening to the movement. Is he grimacing? Is he moving his hands in a dystonic posture, or is he flexing or is he withdrawing, is he localizing कि अरे यहाँ पे मुझे दर्द हुआ था. So all that you have to see. So and then indirect, these are the indirect signs, sensory and motor. तो यहाँ पे दबाने से respond कर रहा है, यहाँ पे दबाने से नहीं respond कर रहा है. So this is also a sign that patient is responding to painful stimulus on the right side, not responding to painful stimulus on the left side. So your observational skills, logical thinking skills, reasoning skills से भी तुम ये derive कर सकते हो. And then after doing all this, you have to identify the common and the treatable causes. So in the casualty, for example, what you have to do is, casualty में patient आया है मतलब कुछ emergency है. So the first thing you do is look at his ABC, airway, breathing and circulation. So once you look at his airway, then TPR, BP, trauma है क्या, उसको कहीं से bleeding हो रहा है क्या, ऑक्सीजन लेवल कैसे, चलो चलो सिस्टर लाओ IV लगाते हैं. Quickly you put on an IV line, then check for his blood sugar, give glucose with thiamine, especially if it's an alcoholic patient, or you might precipitate an encephalopathy in him. Do endotracheal intubation, do blood sugar, saturation, sodium, sugar, oxygen, sodium. These three things you send for the blood samples. अभी ABG तो वहीं के वहीं होने लगता है. And once you are stabilized, then you get the time to ask past history में क्या हुआ था, recent history, trauma, fever, seizure, alcohol, drug use, screening examination from head to toe. You screen his exam, screen for whatever localizing findings are there or not after stabilizing. Then common causes easily diagnosed are head injury, stroke, alcohol or other drug intoxication. So first step in casualty is to stabilize. Even patient coming to ICU, first you have to check whether the patient is stabilized or not. So team approach is required in casualty, the ABC team and the secondary survey team. So the ABC team just does the airway, breathing, circulation management, and then the secondary survey team, so someone senior, everything has been stabilized, and then you take the history. Now ABC, airway, intubate, protecting the neck. Anyone who will let you intubate should be intubated. Any of the following are adequate criteria. GC is less than 9, airway not secure or open. And now you will find that suppose you do your internship in Bharti, so Bharti will have its own protocol. So the senior people in Bharti would have made their own protocol for intubation. So airway not secure or open, respiration is not adequate, any significant respiratory failure, uncertainty regarding direction or rate of mental status changes, particularly if constant observation is not available. Or patient drowsy, stuporous, and his scan needs to be done. And you feel कि बाप रे MRI machine में गया और वहाँ पे arrest हो गया तो क्या? So prophylactically also you may need to intubate. So as I said, most institutes, most good institutes have their own protocol. Our ICU team is fantastic. We also have an MD in emergency medicine here, which is not available in many places. So MD emergency medicine is available in Bharti, and you will always find that there are two people who are resident doctors of the casualty, of the emergency department. So that is also there over here. Now, after airway is breathing. So airway is the patency, the anatomical patency of the airway, and breathing is the functional ability of the lungs to ventilate themselves. So ventilation is something that occurs through the airway, and respiration is something that occurs at the alveolar level and also at the cellular level, where oxygen and carbon dioxide are exchanged. So we are talking about ventilation. So evaluate, is the patient moving adequate air, is respiratory rate appropriate, is gas exchange adequate, that means respiration at the pulmonary level, are breath sounds adequate and symmetrical, and you must assure that oxygenation and ventilation are, whether they are both proper or not. If intubated, do not forget to ventilate. ऐसा नहीं ट्यूब डाल दिया और छोड़ दिया. No, see whether respiratory movements are occurring or not. And remember, when you are intubating, you have to be very careful, because if you push the endotracheal tube too far away, it touches the carina, it can cause ventilatory problems. सो ट्यूब डाल दी, चलो अम्बू बैग से देखा दोनों तरफ जा रहा है ब्रेथ, ऐसा हाँ चलो चलो सब हो गया, ऐसा नहीं. You have to wait there and see whether ventilatory movements are occurring or not. If intubated, don't forget to ventilate, identify and immediately treat problems like pneumothorax, airway obstruction, etc. So the process of intubation also has associated complications. So you have to be sure that those complications have not occurred. Now circulation. So you have to ABC. So circulation, is the patient in shock? So check the pulses. check heart rate, check blood pressure, check the perfusion. Remember, hypotension is a late sign of shock. Before that, other changes occur. Start treatment for shock. Do not restrict fluids in comatose patient with inadequate vascular volume. Cardiac output and cerebral perfusion are much more important than fluid restriction. तो फिर उसके किडनीज को क्या होगा, ऐसा होगा, वैसा होगा, वो टाइम नहीं है वो सब सोचने का. योर ड्यूटी एज अ कैजुअलिटी मेंबर इज टू start the IV line and start the fluids if the BP is on the lower side. So be sensitive towards presence or absence of shock. And remember, the post cardiac arrest encephalopathy is known as hypoxic ischemic encephalopathy. It is not just hypoxic. क्योंकि ऑक्सीजन ले कौन जाता है सारे सेल्स के पास, ब्लड लेके जाता है, मगर ब्लड ही नहीं पहुंच रहा होगा. देयर इज अ लॉट ऑफ वेंटिलेशन गोइंग ऑन, but if there is hypotension, that blood is unable to reach at the required pressure, cerebral perfusion pressure. It is unable to reach at a particular pressure to each and every neuron of the brain. So perfusion is very important, and therefore circulation and maintaining a blood pressure is important. नाउ यूज आइसोटोनिक सॉल्यूशंस. तो हमेशा तुम लोग वार्ड में चाहते हो तो आंखें खुली रखो, सी व्हाट फ्लूइड द पेशेंट इज गेटिंग. So the commonest fluids being given are normal saline and dextrose normal saline. 5% dextrose is a hypotonic solution. पानी और शक्कर है वो सिर्फ. It is hypotonic solution, whereas our plasma has got sodium, potassium, and all those electrolytes. So if you give just 5% dextrose, you're giving a hypotonic solution. So you have to give DNS or NS or RL. Ringer's lactate has got, besides sodium, it has got other electrolytes also. So these are isotonic solutions. Do not use hypotonic solutions to treat shock, especially patients or possible cerebral edema. Identify life-threatening hemorrhage and control it. For example, patient is comatose. Every time the answer is not neurological. One of the first cases I presented in my residency program when I was doing neurology was a patient who had come with splenic rupture. He was a young boy and came in a comatose state, and he had hypotension, and they gave a history, the relatives gave history of a blunt trauma, and we did his sonography, and his spleen was ruptured and splenectomy was done, and his life was saved. So this was in the first month of my joining my neurology training program. One of the cases I discussed as a neurology resident was a young boy of splenic tear because of trauma. So identifying life-threatening hemorrhage and controlling it is extremely essential. So keep your mind open and understand that coma is not just something related to the brain. It is involving all the systems. So management, now we come to what is the neurologic disability. So once we have done the ABC, airway, breathing, circulation, then we think about neurology, which is why my first slide was that Spider-Man slide, that coma concerns everyone, altered sensorium concerns everyone. तो ABC हो गया, patient stable हो गया, और उसके बाद then now you have to think about the neurological deficit. So in Glasgow, a group of doctors realized that ये evaluation patient का ठीक से नहीं हो रहा है, and every time a doctor will not be available over there to evaluate the patient, because most of the time it is the nurses who are attending to the patient, and we need, as I told you, for non-convulsive status, the patient sensorium is fluctuating. तो patient का sensorium fluctuating होगा, तो how do we document कि पहले patient ऐसा था, फिर ऐसा हो गया, अब ऐसा हो गया? So how do you document? So we need something to measure the sensorium by. So they developed this scale known as Glasgow Coma Scale. So Glasgow Coma Scale is not an absolutely fantastic scale, but for many years it was the best scale that we could get, because it was simple and even paramedical staff could apply it. अंडरस्टैंड दिस. और ऐसी ग्लासगो कोमा स्केल अगर तुम लोगों को भी नहीं मालूम होगी तो दैट इज वेरी वेरी सैड, एंड देन द टीचर्स कोल्ड यू. So Glasgow Coma Scale was meant so that even the nurses can monitor the patient, so provides easily reproducible and somewhat precise measurement of the sensorium. So patient can monitor the sensorium and same रहेंगे, just like a system maintains BP chart. So same रहेंगे, just like a system maintains BP chart. just like a system maintains input output chart. Similarly, Glasgow Coma Scale can be written down time and again: eye movement, motor response, and verbal response. So these are the three components. Score is derived by adding the score for each component. Eye opening gets 4 points, verbal response gets 5 points, and best motor response gets 6 points. So you have eye opening, spontaneous is 4, eye opening to speech, matlab chacha aankhein kholo, that is 3. Eye opening to pain, chacha aankhein kholo, he is not opening, and then you give a painful stimulus and eyes are open, so that is 2. And no eye opening even to pain, that is 1. Verbal response, patient is talking, you ask him questions, he is oriented, so that is 5. Patient is talking but the confusion is there in his conversation, not oriented, that is 4. Patient is talking but the words are jargon, they are inappropriate, don't make any sense, but you can hear them, so that is 3. The patient is making some sounds, grunting, something like that, that is 2. And no verbal response is none. Best motor response, 6 means he obeys the commands that you give him for a specific motor activity. So 5 means he is able to localize. 4 means he withdraws. 3 means abnormal flexion. 2 is abnormal extension, and 1 is no response. So normal is 6 plus 4 plus 5, that is 15. And worst is 1 plus 1 plus 1, that is 3. So normal Glasgow Coma Scale is 15. So I hope all of you are 15 and nobody is confused, nobody is sleeping, nobody is drowsy. So I hope that all of you are 15 right now. So that is Glasgow Coma Scale. So and understand the reason for Glasgow coma scale, क्योंकि मैं यहाँ देखती हूँ रेसिडेंट्स को लगता है GCS कैलकुलेट किया मतलब न्यूरोलॉजिकल एग्जामिनेशन हो गया. नो, Glasgow Coma Scale is a very, very rough guide. It is just so that you can record the fluctuations over time. You cannot diagnose someone by Glasgow Coma Scale. You can prognosticate. You can understand whether he is improving or worsening. So, which is why secondary examination secondary survey or general examination is important, where you see the vital signs, you check for fever and hypothermia, you look at the breathing patterns, you see whether the pulse rate is increasing or decreasing. If it is raised ICP, then the patient will have bradycardia. Then you look at the blood pressure, is there hypotension, is there hypertension, you find out about that. Then you look at the skin. Cyanosis, important. Pallor, important. Bruises, important. Cherry red coloration, carbon monoxide poisoning, important. Just now today I had a patient who had come for follow-up. She was a patient of young girl doing her pharmacology course, pharmacy, B-Pharm. And she was admitted just before lockdown started with carbon monoxide poisoning. कहाँ से हुआ उसको carbon monoxide poisoning? गैस गीजर एनकेफेलोपैथी. गैस गीजर होता है बाथरूम्स में, एग्जॉस्ट नहीं लगाते, गैस का जो भी सोर्स है वो अंदर होता है. And then one fine day the girl has a head bath and a long bath on a Sunday morning. The lot of steam is there in the bathroom, and the gas is also leaking, low oxygen levels, so she inhales all that carbon monoxide, and we get what is known as gas geyser encephalopathy. One of the longest series on gas geyser encephalopathy is by my colleague Dr. Rahul Kulkarni, and was reported very aggressively from Pune itself. And we keep on getting these patients in spite of trying to create awareness for it. So that is carbon monoxide poisoning. Now this girl is doing very well, she is improved from all her deficits. So CSF leak हो रही कि नहीं हो रही, bleeding हो रहा है क्या ENT से, especially patients of trauma. Then rash, meningococcal meningitis will have a small petechial rash all over. Sweating, patient if is hypoglycemic or in shock, then there will be sweating. So lot of findings in skin: dry skin, diabetic ketoacidosis, uremia, loss of turgor, then that is dehydration, pressure sores, that means minimally conscious state, persistent vegetative state. Those patients coming with coma, they could already be having pressure sores. Then breath odor. So see how much examination is to be done, because patient is not giving history and we are being CIDs. We are trying to find out कि कितना पता चल सकता है. So alcohol लिया है क्या? Except vodka, everything smells. Spoiled fruit odor will be decay. Uriniferous odor will be there in uremic encephalopathy. Hepatic coma will have musty odor. Burnt almond smell in cyanide poisoning. So all these textbooks, they will give you all these things. And now we come to the neurological examination of the comatose patients, which over smart residents, they will write cannot be tested. but that is not smartness, that is over smartness. It doesn't get you anywhere. So you are observers. As clinicians, you are observers, and remember to observe, watch the patient. So look at the patient, watch. And let me tell you, in a comatose patient, however much your technology will advance, your artificial intelligence will develop algorithms for monitoring all the parameters of ours, but there are certain areas in medicine where clinical medicine will always be important, and one of those areas is altered sensorium, because you have to have your experience, you have to have your reading, and you have to have your observation skills. तो पेशेंट की स्पॉन्टेनियस मूवमेंट्स कैसी है, अवॉइडेंस मूवमेंट्स है क्या, क्लोज पिकिंग मूवमेंट्स है क्या, is this patient was it delirious and now he has become stuporous, position of head, neck and eyes कैसी है, patterns of breathing कैसी है, so movements and postures. And you have to check for responsiveness, level of consciousness, नाम पुकारो उसका, simple commands दो, tactile stimulus दो, painful stimulus दो, and this has to be recorded like that. पेशेंट रिस्पॉन्ड्स टू रेपिटेटिव टैक्टाइल स्टिमुलस, या फिर पेशेंट रिस्पॉन्ड्स टू टैक्टाइल स्टिमुलेशन एंड परसुएशन. मैं बार बार बात कर रही हूँ तो वो चाचा खोल रहे हैं आंखें, मगर पेशेंट डज नॉट रिस्पॉन्ड टू रिपीटेटिव परसुएशन. That also becomes a finding on the next day, perhaps. That means he is worsened. So, Glasgow Coma Scale, as I said, it's a screening test: eye opening, motor response, verbal response. Now, these are the postures. So this is decorticate and this is decorticate and this is decerebrate. Now depending upon whether the complete hemisphere is gone, accordingly the plantar will be upgoing or downgoing. If the subcortical areas are spared, now this is bilateral decorticate, this is unilateral decorticate, and this is decerebration. This is uh, this kind of movement is decerebrate posturing. So, and here see, you can see someone is giving painful stimulation. So what happens on painful stimulation? This is decortication and this is decerebration. Decortication मतलब cortex काम नहीं कर रहा है, और decerebration मतलब cerebrum काम नहीं कर रहा है. So that is how it happens. Now, neck rigidity is important because infective pathologies and subarachnoid hemorrhage, they will present with neck rigidity. So, neck rigidity, देखना भूलना मत. In your PJ Mehta and all these textbooks, neck rigidity says आखिरी आखिरी में दिया है. But that is the thing that can clinch a diagnosis in some of the patients. So, remember, it has to be done. Now, focal neurological deficits, the way of examining these patients is different. कर नहीं सकते ऐसा नहीं है, जो कॉन्शियस पेशेंट है उसको एग्जामिन करने का तरीका अलग है, और जो ऑल्टर्ड सेंसोरियम पेशेंट है उसको एग्जामिन करने का तरीका अलग है. सो आईज, फेस, अपर लिम्स, लोअर लिम्स, एंड ऑफ कोर्स ट्रंक आल्सो यू कैन ऐड देयर. सो सेंसरी एंड सिमिलरली मोटर, आईज, फेस, अपर लिम, लोअर लिम. तो ट्रंक का हम मोटर मूवमेंट ज्यादा नहीं देखते, मगर सेंसरी यू कैन चेक इन एडिशन ऑन द चेस्ट एंड ट्रंक, चेस्ट एंड एब्डोमेन ऑल्सो. So you have to look at the eyes, you have to look at corneals, conjunctivals, face pay. You can give painful stimulation to this particular area where supraorbital nerve is coming. So we press hard over here and it's very painful. And then the patient, that is what they had shown over here also. This is where they are giving the painful stimulation. Another way of giving painful stimulation is sternal pressure. And a very bad and inhuman way of painful stimulation is squeezing the nipples, not to be done. Another way where sometimes we do have to resort is to press on the nail bed. Press on the nail bed, that is extremely painful, but this is to be done only when trying to monitor the patient, and I usually resort to sternal pressure. So I do not use these other modalities, or at the most pressure on the orbit. So now eyes. Most useful is pupil size and reactivity. Then you check for ocular movement, then oculovestibular reflexes, then you check for breathing patterns. And eye study of the eye, the doll's eye movement and the breathing patterns is important because it helps in localizing the level, and it helps us assess how localizes. It helps us assess the integrity of midbrain and rostral pons. So pupils and their reactions, metabolic causes of coma, then that time the Pupils are either normal sized or small sized and reacting to light. Then in Horner's syndrome, there will be small sized pupils on one side. Then diencephalic also, they are small and reactive. Then tactile plate, ये जो superior colliculus, inferior colliculus है, that is tactile plate. In that, if the lesion is over there, then you will have a large fixed pupil with hippus. And if the third nerve is gone, then that side you will have dilated fixed pupil, especially uncal herniation. The pupillary size change is something that is aggressively monitored in the ICUs. Then pontine lesion, you will have bilateral pinpoint pupils, and midbrain lesions, you will have mid position pupils which are fixed. So now eyes and gaze, supratentorial and infratentorial. Supratentorially मतलब मिड ब्रेन के भी ऊपर, तो आईज के जो फाइबर्स है फ्रंटल आई फील्ड से जो थर्ड फोर्थ सिक्स नर्व न्यूक्लियस के पास जा रहे हैं, they have not yet crossed. So towards the lesion, gaze is possible. And infratentorially, that means after crossing, the eyes will look away from the lesion gaze. So paralytic lesion. And so the lesion in the brain is either paralytic or irritant. So if it's an infarct, it's a paralytic lesion. If it's a hemorrhage, it can be an irritant lesion. Now, all old-time teachers, they like to ask the permutation and combination of these questions. So irritant lesion agar hoga, to supratentorially there is forced gaze because that lesion is irritating. So it's like a small non-convulsive seizure. It is forcing the gaze to look away from the lesion. It's irritating, so it's like a seizure. So gaze is looking away from the lesion. Whereas paralytic lesion will be that gaze is paralyzed, so eyes keep on looking. There is a gaze preference to look towards the lesion. So infratentorially will be opposite. Now non-convulsive seizures, therefore non-convulsive seizures may eyes are the give way. Rest of the patient is looking as if he is not moving at all, but you look at his eyes and you will see that the gaze is going like that, like that, like that. It's staying there, it's staying there, staying there. Then slightly for some time it comes like that, and then again it goes back. So that gaze is the give way that something in the brain is irritating. So in such a situation, any index of suspicion for non-convulsive status, you do an EEG, you find those discharges, and you can see that the patient improves after anticonvulsants. If the index of suspicion is high, we even do a bedside midazolam test, and we see that whether after midazolam, whether the patient is improving instead of becoming more drowsy. So that is another way where non-convulsive status can be assessed. So eye movements, roving eye movements. Eye deviate to the side of the lesion. We saw that left frontal lobe lesion. Then roving eye movements, that means eyes are going like that, like that, like that. So it's a diffuse cerebral dysfunction. Then exotropic position, both down and in. Both down and in, eye is a thalamic lesion. Eyes deviate downwards, rising sun or setting sun sign. So these two we saw, frontal lobe lesion, irritant, paralytic, supratentorial, infratentorial. Then this is thalamic lesion. Then this is left third nerve. The pupil is dilated and the eyeball is shifted because sixth nerve is acting. Then this is right fourth nerve palsy. Patient is looking to the side of the lesion. And plus, if the patient is conscious, of course, there will be head tilt, that is different. Sorry, right sixth nerve lesion. Then, so this is the medial because the third nerve is acting unopposed. So there will be medial rectus pulling the eyeball. And then this is left hypertropia, third or fourth nuclear or nerve injury, lesion of medial longitudinal, where there is um, a squint, which is what is it called? Skew division of eyes. So here everywhere they are mostly parallel, but here one eyeball has got in a different plane and the other has gone different in a different plane. So third or fourth nuclear or nerve injury or lesion of the medial longitudinal fasciculus. So patient is unconscious. We are just picking up his eyelids to see which of these things he has. So eye movements, again see how many slides for eyes. Retraction and convergence nystagmus. So that is midbrain. So retraction and convergence nystagmus. So convergence nystagmus means if these two are the eyeballs, there is this kind of a nystagmus. They converge and then they go back, and then they converge and they go back. So that is midbrain, or pineal lesion also can press on the midbrain and cause these tactile plate things. Then ocular bobbing. So it goes down and bobs up, goes down and bobs up. So this is ocular bobbing. I am using my fists to represent the eyeballs. I hope you can see me.
Yes, ma'am.
Okay, so someone is awake. So going down and coming up, that is bobbing. So eyeballs are bobbing up. So that is midbrain and pons. And ocular dipping matlab goes up and comes down. Goes up and comes down. So that is ocular dipping. And ocular dipping can occur with diffuse lesions of the brainstem or with lower brainstem lesions also. Then progressive loss of blinking can also occur. So structural lesions of brainstem which cause coma or abolish most, they will abolish most or all conjugate eye movements because conjugate eye movements are dependent on integrity of the brainstem. Then metabolic disorders generally do not. So hepatic coma or anticonvulsant overdose, they will not abolish the conjugate eye movement. So you will get roving eye movements in metabolic and toxic causes. So eyeballs are moving. So oculocephalic reflex on the doll's eye movement, unimpeded function of third nerve, midbrain, pons, and integrators. So this much you can understand by seeing the doll's eye movement, and which is why because sometimes if it is a toxic thing, you how many toxins are you going to assess, and your MRI may be normal. So then to understand how the brain is functioning, you need to do this. So loss of cortical inhibition that normally holds these movements in check has occurred. So whenever there is loss, so whenever the third nerve nucleus, that means upper midbrain, pons, and the integrator nuclei, whenever they are damaged, that means the parapontine reticular formation where the horizontal gaze center is there. When all those structures are damaged, then you can get loss of doll's eye movements. So that is important. So oculovestibular or caloric testing, which is one of the important tests for diagnosing brain death at the bedside. So you take 10 ml of cold water. Normally, what we do, we put the, so there is a syringe with a cannula, and we put the water in the external auditory canal, and slow towards the irritated ear and opposite nystagmus will. So slow movement will come towards the, if my left ear is being insufflated, so there will be slow movement and nystagmus, slow movement and nystagmus towards low left, slow movement and nystagmus. So cows, cold opposite warm, same. So that is 10 ml cold water. So there will be cold opposite nystagmus. If we give warm water, then it will be same side nystagmus. So supratentorial lesions अगर होंगे तो there will be the tonic phase, tonically deviated. And so brainstem lesion अगर होगा तो bilaterally it will be absent, or it may be present absent on one side and present on the other side if it is only a partial brainstem lesion. Now, supracortical is the code word we have for psychogenic. So these patients exist, supracortical unresponsiveness, psychogenic unresponsiveness, and they need to be caught. And one of the simplest tests we used to do when I was a resident, where I was a resident, we used to put ether. So ether is available in most hospitals, and it is extremely irritating to inhale, extremely irritating. So we used to put ether on a gauze and put it on the nose, and on inhaling the patient used to wake up. So there are many tricks to diagnose psychogenic unresponsiveness, and therefore, as we say that medicine is not just skill. It is also art, and that will occur as you gain more and more experience. So now we come to breathing patterns. So Kind-Stokes breathing is this kind of a breathing. Hyperventilate, breathing increases, then decreases, and then there is apnea for some time. Then again breath start, grow, less. Apnea. So this is Kind-Stokes breathing, and that occurs with a lesion in the cerebral cortices. Bilateral lesion agar hoga, so this is what the patient has. So a decerebrated patient could be having a Kind-Stokes breathing. Then central neurogenic hyperventilation when the midbrains have a lesion. So this particular lesion, what you get is CNH, central neurogenic hyperventilation. Apneistic breathing, there is a breath, holds, exhales, and then nothing for some time, nothing. Suddenly there is a breath, holds for some time, and then he exhales. And again, there's no breath, no breath, no breath, no breath. Again, a breath. So this is what the graph of breathing will look like in an apneustic breathing, where again नीचे आ गए, mid brain से थोड़ा नीचे आ गए. So pontomesencephalic. This is pontomesencephalic. ये मिड ब्रेन का पॉन्स बनने लगा ना. So this is pontomesencephalic. So this is ponto. So this is also ponto. This is also ponto. This is also ponto. So all these three are pontine lesions. And short cycle Kind-Stokes respiration. मतलब this Kind-Stokes, this much has occurred over 1 minute. Twice or thrice this that might occur. So these are short breaths. So this is a short cycle Kind-Stokes. So that will occur in a lower pons region. And as you come down to medulla, medulla is where the respiratory center is. So there is absolutely, it is like atrial fibrillation of the respiratory center. कुछ भी हो रहा है, ब्रेथ आ रही जा रही आ रही जा रही नहीं आ रही कभी आ रही फिर गई. So this can very often be the terminal breathing of the patient. So that is Biot's breathing. So raised ICP, I hope you all are following what I'm saying. This is an extensive topic.
Yes, ma'am.
Okay, thank you. Only one person can speak over here. ऐसा कुछ है क्या? Are the others awake? Anusha, Ashita, Arya,
Yes, ma'am.
Nimisha, Palak, Rutuja. Are you all awake?
Yes, ma'am.
Give a big yes. मेरे लिए भी थोड़ा motivation हो जाए.
Yes, ma'am.
Okay.
Yes, ma'am.
Yes, ma'am.
Yes, ma'am.
Because otherwise on these online lectures, I feel I'm talking to myself in an empty room. Okay. So now raised ICP, in raised ICP, your relatives are going to give you history. The caregivers of the patient are going to give history कि हाँ कुछ दिन से बोल रहा था सर दर्द हो रहा है और उल्टियाँ कर रहा था और especially सुबह सुबह 4 बजे उठता था. So 3 a.m. 4 a.m. is the time when raised ICP is maximum if you are living in the Indian time zone. If you are living in the UK time zone, then we'll have to calculate. So sleep is the time when your respiratory centers are working less, your venous return has increased, and because of that your posture is different. So because of that the ICP can increase during sleep, and because there is stagnation of blood in the brain, and venous return has decreased, sorry, from the superior vena cava, so that there is stagnation of blood in the supra SVC region, and that can increase the ICP beyond the critical limit in the early morning. So 3 a.m., 4 a.m. is the time for raised ICP wale headaches to occur and vomiting, and diplopia if the patient has had. Then bradycardia, hypertension, subhyaloid retinal hemorrhages, papilledema. Again, see, eyes are telling us this story. So these are the features of raised ICP. Then so ये सब हमने देखा पेशेंट का, एंड देन वी थिंक ऑफ इन्वेस्टिगेटिंग. सो बेसिक इन्वेस्टिगेशंस ऑब्वियसली कैजुअलिटी से चले गए हैं. अगर पेशेंट अभी आईसीयू में आया है, नाउ वी हैव टू थिंक अबाउट द मेटाबॉलिक कॉजेज, वी हैव टू थिंक अबाउट द टॉक्सिक कॉजेज. So investigations may you have to think about the structural causes also. So you do CT scan, you do MRI, you do blood levels. EEG is something in most of the Indian ICUs we keep for a later investigation. Very, very few ICUs have EEG monitor like they have an ECG monitor. Very few ICUs have that. So all the places where they are driven by neurologists and neurointensive care people, only they will have these EEG monitors. So where I was in Nagpur, we had that EEG monitor in the place where I did my neurology from. But otherwise, in most of the standard multi-specialty hospitals, there is no EEG monitor. Here, we do not have. But we have a bedside EEG in the ICU. So we can do a bedside EEG. And then, of course, infective causes, or sometimes even in subarachnoid, we need to do CSF. Now, supratentorial mass lesions like hematoma, neoplasm, abscess, contusion, vascular accidents, and diffuse axonal damages, all this will be seen on the MRI. So this is CT scan, and CT scan advantages, it is available in most places, and it is done very quickly. You don't really have to anesthetize the patient and all, just hold him down and it's done quickly. So supratentorial mass lesions, one of the important ones to rule out is a subdural hematoma. Dura ke just niche, it is a crescent moon like thing. So that is the subdural hematoma. What is more frightening is an epidural hematoma. This is like the pregnant lady sign. So it is a biconvex lesion and it can strip the dura fat like that because it is epidural, and it can strip that dura from the skull and it can just increase and it can be life threatening. So the patient who came, young male patient, pillion rider on a bike, and he fell down and he helped his friend up, and then somehow somebody brought them to the hospital and someone says, and the patient says कि हाँ मैं गिर गया था तब थोड़ी देर के लिए मैं बेहोश था मगर अब मैं ठीक हूँ, and you do his scan and you see this epidural hematoma, you have to worry because that epidural hematoma has a potential to fat se become a bigger epidural hematoma. So epidural hematoma is a bigger emergency than a subdural hematoma. So keep a watch on that young boy. He has no atrophy, and so there is no space available for expansion, and he may be the candidate. The friend who has a subdural hematoma or who has a big CLW, he may not have any problem later on 5 days later, but this epidural needs your attention. So remember that epidural needs attention. So base of skull fractures might occur, and now here you can see a right temporal hematoma. Cerebral edema, hydrocephalus is also there. See here you can see large temporal horns. So that's hydrocephalus. Usually temporal horns are not seen at all. And there is pneumocephalus. I don't think that is seen well over here, but air looks bright. I mean, it looks jet black rather. It is conspicuous by its jet blackness. So that is pneumocephalus. Now this is a cerebral abscess that can also present suddenly because one fine day it reaches that critical mass where the sensorium is altered. So supratentorial mass lesions pathophysiology altered consciousness is based on increased pressure, herniation and diffuse bilateral lesions. Now there are different herniation syndromes. There is central herniation where the whole brain kind of sinks down. So rostrocaudal progression. तो उसकी वजह से फिर क्या है, सबसे नीचे क्या है, मेडुला है. मेडुला में क्या है, रेस्पिरेटरी है, सेंटर है, मोटर सेंटर है एंड कार्डियक सेंटर है. So when the whole brain sinks down, the medulla gets pressed against the foramen magnum. So that is central herniation, and patient may not have other focal findings. So sudden bilateral signs. And uncal herniation means एक side से one temporal lobe is herniating this side. So there is rostrocaudal progression also, but along with that, the third nerve which is going like that, it gets pressed against the medial temporal lobe, and you can get contralateral motor findings because the cerebral peduncle going like that is also twisted by the medial temporal lobe which is pressing on it. So you will get contralateral motor findings because those fibers will cross afterwards. तो वो इधर से press होंगे तो there will be left hemiparesis. So this is the herniation syndrome. This is the central herniation. This is uncal herniation. This is transfalcine, subfalcine herniation. So cingulate lobe is herniating. And this is herniation across the gap in the skull fracture. So this herniation can also occur. So this is the normal anatomy, and this is the line beyond which you can measure the herniation. And what happens in herniation, in addition to the actual physical crossing over, you will also get that the one central herniation अगर हुआ तो ये नीचे जाएगा मगर blood vessel उसके साथ नहीं जाएगी. So there will be secondary hemorrhages in the brainstem because these blood vessels get torn. They are very delicately tethered vessels over here, and they'll get torn from the pons, and you will get secondary hemorrhages in the brainstem, and that will lead to additional deficit. So this is the transtentorial herniation, and see this is how it will happen. So this will press on this also, and this is the normal brain and transtentorial herniation and brainstem. So see all these lesions are here, and this brainstem has been pressed. See over here it's not pressed, over here it is pressed along. So differential characteristics, initiating signs usually, just a minute. Excuse me, someone has to sit here. Okay. So differential characteristics of supratentorial mass lesions, initiating signs usually of focal cerebral dysfunction. So usually those the dysfunction progresses So neurologic signs at any given time point to one anatomic area. Diencephalon, midbrain, brainstem, motor signs are often asymmetrical. Plum and Posner were two people who did a lot of bedside clinical studies of patients who are comatose. Infratentorial lesions matlab brainstem or cerebellum ke lesions, they cause coma by directly affecting reticular activating system in pons. Brainstem nuclei and tracts usually are involved with recently focal brainstem findings. So causes of coma: neoplasm, vascular accidents, trauma, cerebellar hemorrhage, infratentorial lesions, demyelinating disease of the brainstem, central pontine myelinolysis. So infratentorial also there are a lot of differential characteristics. Sudden onset होगा, localizing brainstem signs है क्या, oculovestibular abnormalities है क्या, cranial palsies है क्या, bizarre respiratory patterns है क्या. So a lot of dramatic signs you will get in the brainstem. Now homeostatic requirements of brain will just briefly see: oxygen carbon dioxide balance, glucose, blood circulation, cerebral blood flow of minimum of 55 ml per minute per 100 gram, osmolarity, electrolyte balance is required. So sodium, pH, calcium, normal temperature is required by the brain. Intracranial pressure has to be a certain level, and toxins should not be present in the blood. All these are the homeostatic requirements of the brain. बेचारे brain के बहुत ऐसे specific requirements हैं. वो जब disturb हो जाते हैं, any of these gets disturbed, the brain is going to have diffuse dysfunction. So metabolic causes, anything which disturbs the above things. So respiratory, electrolyte, hepatic, renal, infections, and toxins and drugs. So how do you differentiate metabolic coma? Confusion and stupor there will be history कि कुछ दिनों से ये चल रहा था. Motor signs are usually symmetrical. Pupillary reactions are usually preserved. Asterisk is, that means you ask the patient to keep hands like this and he will have this. These are known as flaps or negative myoclonus or asterixis. Seizures can be common. Acid-base imbalance with hyper or hypoventilation is frequent. Iatrogenic drug overdose is also a cause of coma. Intoxication, suicide attempts with sedative drugs, anesthetic agents, sedatives, anticonvulsants, opiates, antidepressants, antipsychotics, and sodium nitroprusside also has got cyanide. Endogenous toxins, that means toxins produced by the body itself. So diabetic ketoacidosis, uremic, hepatic because of ammonia, lactic acid, and water in the neurons, that is hyponatremia. And exogenous toxins are bacterial toxins or drugs. So investigations, you do CT brain MRI for structural lesions, EEG Vera metabolic profile for dysfunction, and CSF examination for infective causes and sometimes for subarachnoid. So drugs, methyl alcohol, ethylene glycol, metabolic acidosis will occur. These are indirect, and directly affecting our general anesthetics, alcohols, opiates, anticonvulsants. So lateralizing deficit अगर होगा तो we think of structural, और if नहीं होगा तो we think of metabolic infective. Seizure activity, as I told, suspect non-convulsive, and that does give lateralizing deficit, concussion. So coma with focal or lateralizing deficit are these causes. Now this is there on YouTube live. I'm going to let this slide be for some time. These are there in your textbooks. And coma without focal signs but with meningeal irritation. So in that you do all these investigations, and the list of investigations is increasing as we are making progress in microbiology and pathology. Coma without focal neurological signs और meningeal irritation, वो जो एकदम पहला चार्ट था, ये उसके सारे सब causes हैं. And now management, we saw initial stabilization, then diagnose, manage the cause, basic supportive management, and prevent complications. And in complication, preventing aspiration pneumonia, urinary infection to be prevented, pressure source to be taken care of, DVT prophylaxis to be given, restraining the patient if he or she is becoming very irritable and agitated in between, and eye lubrication, don't forget that, and position change, and preventing bed sores. So I'm sure you are under stress by now. I am, with so much talking that I have done. So you can reduce your stress by banging your head here. So thank you so much. And if you have any questions, I have only 1 minute for the questions. So please ask. Please read this chapter today. It is an extensive chapter. It is a very interesting chapter. It will look difficult, but I have tried to make it as simple as possible. So if you read it today itself, only then the benefit will be there. So no questions. So I'm going to stop and end the meeting. I hope you enjoyed listening, okay? At least one person has enjoyed.
Yes, ma'am.
Okay.
Yes,
Yes,
ma'am.
ma'am.
Yes, ma'am.
Because neurology is a very dynamic branch. And we hope that at least 4 out of you all should become neurologists, okay? So by